While both concepts are named after the renowned French electrophysiologist Philippe Coumel, they refer to fundamentally different aspects of cardiology. Coumel sign is a specific diagnostic electrocardiographic finding used to localize axillary pathways, whereas Coumel's triangle is a foundational pathophysiological model used to explain how arrhythmias develop. Coumel sign is an electrophysiologic observation seen during orthodromic atrioventricular reentrant tachycardia, such as in Wolff-Parkinson-White syndrome. It states that if a functional bundle branch block develops on the same side as the axillary pathway during the tachycardia cycle length will increase, meaning the heart rate slows down. In orthodromic AVRT, the electrical impulse travels down the AV node, his Purkinje system, and retrograde up the accessory pathway. If an ipsilateral bundle branch block occurs, the impulse can no longer travel down the bundle branch on that side. Instead, it must travel down the contralateral bundle branch, cross the interventricular septum, and then travel up the accessory pathway. This anatomic detour increases the size of the macro reentrant circuit. It manifests as a prolongation of the ventriculoatrial interval, typically by 35 milliseconds or more, and a corresponding increase in the overall tachycardia cycle length. It is highly useful in the EP lab and on surface ECGs to lateralize an accessory pathway. For example, if left bundle branch block develops during AVRT and the tachycardia slows down, it confirms the presence of a left-sided accessory pathway. Coumel's triangle of arrhythmogenesis. Coumel's triangle is a conceptual framework that describes the three necessary elements required for a clinical arrhythmia to initiate and sustain itself. It is most famously applied to atrial fibrillation and ventricular tachycardia. According to Coumel, an arrhythmia is not caused by a single defect, but rather the interaction of three distinct pillars. 1. The arrhythmogenic substrate, the underlying structural or electrophysiological abnormality in the myocardium. This could be myocardial scar tissue from a prior infarction, atrial fibrosis, hypertrophy, or a genetic channelopathy that allows for re-entry or abnormal automaticity. The trigger, the initiating electrical event that sparks the arrhythmia. This is typically an ectopic beat, such as a premature atrial contraction originating from the pulmonary veins or a premature ventricular contraction. The modulating factors, the dynamic transient influences that alter the electrophysiological properties of the heart, making the substrate susceptible to the trigger. The most prominent modulator is the autonomic nervous system, fluctuations in sympathetic or parasympathetic vagal tone. But it can also include acute ischemia, electrolyte imbalances, or drug toxicity. Clinical utility. It forms the basis of arrhythmia management. Therapy aims to address one or more sides of the triangle, such as ablating the substrate or trigger, or using beta blockers to alter the autonomic modulator. Here is a comparison. Concept type: Coumel's law or sign, diagnostic electrocardiographic finding, while Coumel's triangle is pathophysiological framework or model. Primary application in orthodromic AVRT, that is WPW syndrome, for Coumel sign, while Coumel's triangle is applicable to all clinical arrhythmias, especially atrial fibrillation and ventricular tachycardia. The core principle: ipsilateral bundle branch block increases the VA interval and slows tachycardia cycle length. Then Coumel sign. Coumel's triangle. Arrhythmias require the interaction of a substrate, a trigger, and a modulator. Clinical goal. Coumel's sign or law to localize the anatomical side of an accessory pathway. Coumel's triangle to guide therapeutic strategies by targeting the specific mechanisms of an arrhythmia.